Hello and good afternoon friends, welcome once again to CEC EduSet live lecture. Dear friends, as you know that we are carrying series of lectures on cancers. We conducted numerous lectures on cancers and tried to identify and study about various type of cancers. Today also we are going to take a deep insight into cancers, and today we are going to discuss about breast cancers, what breast cancers are, how they occur, what are the causes, and how they can be cured, or what are the remedies or the treatments available. And for this we have again with us in our studios Padma Shri Professor P.K. Julka. Dr. Julka is a professor of radiotherapy and he is dean at All India Institute of Medical Sciences. So first of all, I would like to welcome our guest Professor Julka. Professor Julka, welcome to the EduSet lecture. Although in previous lecture we had a very good insight into the topic, that is cancer, we came across. Exactly. We studied about general cancers, but specifically we are going to talk about breast cancers today. So with the help of your experience, I hope that we would be able to extract more and more through this lecture of yours. So over to you, sir.
Okay, we are going to talk about breast cancer today because earlier I had talked about various types of cancers, and today we'll focus on breast cancer. Now, what is breast cancer? I'll just show you the scenario. The scenario is breast cancer is most common cancer among women globally, not only in India. Globally, the commonest cancer. As you see here, it is 25 to 30% of all cancers, and most common cause of cancer related mortality amongst women. From 2008 to 2012, the incidence increased by 20% and mortality by 14%. Next 2 decades, we are expecting 60% of new cases and 70% mortality in developing countries. You can see the implications. Developing countries like India, rapidly rising incidence and high mortality. Now, if we see Globocan data of 2012, the breast cancer incidence and mortality, the incidence is also high. The blue bars represent the incidence and the red bars represent the mortality. The mortality is also quite high as regards the other cancers. And here if we see the Globocan 2012, the global incidence, earlier we saw the incidence in India, and here you see the global incidence. If you see closely, then you see in the Southeastern Asia, where India comes, the mortality is pretty high and the incidence is also high. Now, as compared to the Western population, in almost all the countries, as you are seeing here, the incidence is rising, except in US, where you see the bar is at plateau. In India also it is rising. Now, what are the risk factors? We call them non-modifiable and modifiable. Non-modifiable means that you cannot modify them. Number one, gender and age. Gender means if you are a female, then you are more prone for breast cancer. This is obvious, you can't change your gender. You can change nowadays, but it's difficult. We always call it a non-modifiable. And age. Age, that means elderly age group. Females, they are more prone for breast cancer. Personal cancer history, if you have cancer in the family or personal cancer history of any cancer, then you are more prone for breast cancer. Then family history of breast cancer and genetics. Family history means that if your mother or from mother's side anybody has cancer, or there are genes called BRCA1 and BRCA2 which occur in familial type of cancer, then you are more prone for this cancer, breast cancer. Early menses and late menopause. This is also a very common cause. Why it is common? Because if you have menses very early, say at the age of 8, and menopause at the age of 50 or 60, then you are more exposed to female hormones. and female hormone called estrogen is the culprit. So then you are more exposed to that hormone, you are more prone for breast cancer. Now then breast density, if your breast is very dense, that we can find out on a simple ultrasound, we can find out on MRI, breast density is high, they are more prone for breast cancer. Then there are certain benign breast conditions where they are more prone for breast cancer. Now there are certain modifiable risk factors which you can modify. That means body weight. Body weight you can easily modify, though it's not that easy, but still we would like you to modify the body weight, because keep your weight low, don't be overweight, physical activity should go on, don't have sedentary lifestyle, alcohol use should be moderated, that means you should try to avoid alcohol, and smoking should absolutely be avoided, because smoking leads to 40% of all the cancers which are occurring not only in India, in the world. So we must avoid smoking of any type, smoking, hookah, bidi, cigarette, any smoking. Then exposure to hormones, that means as I told you, female hormones, estrogens, some people take it as a pill or as hormone replacement therapy, but nowadays hormone replacement therapy carries less of estrogen. Pregnancy and breastfeeding. Now breastfeeding is very important, because if you don't breastfeed your children, then you are more prone for breast cancer. Then radiation exposure. In the early years, if you have radiation exposure, you are more prone for breast cancer. Now this has been shown already in the studies on lymphomas, where the young girls were exposed to radiation. Now if you see, obesity leads to breast cancer. Now how does obesity lead to breast cancer? You see the estrogen pathway, estradiol and all these hormones which can lead to increased cell proliferation, increased cell survival and increased angiogenesis. Angiogenesis means increased blood flow through the tumor. So this is how the adipose tissue, the fatty tissue, can lead to breast cancer. Now you must avoid the obesity. Obesity means the fatness. You must avoid it. Now here you see effect of obesity on pathogenesis, on the prognosis after early stage breast cancer. Here you see, if you are seeing the upper bar, this is locoregional and distant metastasis. If one has breast cancer, then he or she is likely to have more of locoregional recurrence, likely to have distant metastasis. Distant metastasis means spread to other areas. If the BMI is more than 30, what does it mean? 30 kilogram per meter square. That means your body weight divided by your square meter area, surface area. Now if we see the prognosis after early stage, the breast cancer related death, the deaths are also high if your BMI is over 30. So if you are fat, your risk of death from breast cancer will be very high. So you must avoid obesity. This is very important. Now how can we prevent breast cancer? These are the various preventive hormones where we can give in cases who are at high risk, but best way to prevent is early detection, which I shall be showing you. Now these are various hormone strategies. For example, Tamoxifen and Raloxifene studies are already out. There are other studies going on with aromatase inhibitors for prevention of breast cancer. If you give Tamoxifen for 5 years, then you can prevent breast cancer for a long time, but need to validate with long-term follow-up. Now selective estrogen receptor modulators in prevention of breast cancer, this is updated meta-analysis. Now what does this show? That there are, like I told you, SERMs, we call it selective estrogen receptor modulator. Now these are like Tamoxifen, like Raloxifene, all these medicines they prevent breast cancer for a long time. As you see the curve, patients with breast cancer, follow-up of 10 years, at 10 years also the incidence is low if you are given tamoxifen for 5 years. And another drug called anastrozole, which is aromatase inhibitor, if you give it for 5 years, again your incidence will be low. This is according to these studies. Now again important aspect is screening. Now should we resort to screening or not? Because 1.2 billion population of India, is screening feasible? Now this here will show you how you can self-detect your lump, any lump in the breast. Here you see a female detecting the lump by herself. We always say breast self-examination, then examination by a physician, then mammogram. Now first is the breast self-examination. If you find something, then you get it examined by a physician and then you get a mammogram done. Mammogram is a special X-ray, and here you see that in the US Preventive Task Force, they tell us that it is against clinician teaching women how to perform breast self-examination. Now, what I want to tell you that breast self-examination for our country, we should do it because we should tell the females to get it done after the age of 20. Now, if we see the treatment and prognosis, and here you see the molecular classification of breast cancer, and as I showed you the molecular classification, nowadays what we are doing molecular studies in all the cancers. Now, what do we mean by molecular studies? We are studying various types of cancers by various molecular classifications. Now, we have like estrogen receptor positive, hormone receptor, the progesterone receptor positive. We have third is HER2 gene, which may be positive. So, we call them luminal A, luminal B and basal-like. Basal-like means which is triple negative. And here you see the stage at diagnosis. If it is stage 1, your survival percentage is very good. If it is stage 2, it falls down. As you see stage 3, it falls further. Stage 4, it falls further down. Now, what are the treatment modalities? We always say it is a combined modality approach. Combined modality means surgery, radiotherapy, chemotherapy, hormonal therapy. So, hormone therapy can come with chemo, after chemo, or hormone therapy can come after radiation. Now, what is the evolution of treatment? If we see the evolution of treatment, earlier we used to do extended radical mastectomy. We used to remove the whole breast, the whole tissue beneath the breast, and now then we shifted to modified radical mastectomy, only the breast and the axillary nodes. Then we shifted to breast conservation. Less and less surgery is being performed. Breast conservation means that only the lump is removed and not the whole breast. Then radiation also, we were giving loco-regional radiation, that means radiation to the breast and axilla and supraclavicular area above the clavicle, the collarbone. Then came whole breast RT, radiotherapy, and now it is accelerated partial breast radiation. Now, recent studies have shown that partial breast radiation is equivalent to whole breast radiation. So, we have chemotherapy for locally advanced, we give chemo first, then sometimes we give hormone therapy for hormone receptor positive, and then we have biological therapies. Now, there are various oncotype DX, MammaPrint and PAM50 signatures. These are gene signatures for early cases where we are not sure whether to give chemo or not. They are estrogen and progesterone receptor positive cases, and they can be given only hormones. But whether to give chemo or not, we have these signatures which shows risk of recurrence, whether the risk of recurrence is high or risk of recurrence is low, or risk of recurrence is intermediate. For low risk, we give only hormones. For high risk, we give chemo followed by hormones. Now, there are MIND-ACT and TAILOR-X trial which are ongoing, which I will tell you whether in intermediate risk where we can give chemo or not. Now, if you see this, the psychosocial outcome, the quality of life. Now, we talk of quality of life also in treatment, because treatment does not mean that you treat only the local part. You have to treat the patient as a whole. You can't treat only the disease. Now, if we see stratification of sentinel nodes, because sentinel, you know, the sentry who stands at the gate. So, these are the nodes which are at the gate of breast. What is the gate of breast? That is the axilla, armpit. So, early breast cancer, axillary nodal dissection is not required. We do only sentinel node biopsy. And if sentinel node biopsy shows 1 to 2 nodes, then we can give radiotherapy. There is no need for axillary dissection. If we are removing the whole breast, then axillary dissection can be done. But what is the harm? Harm in axillary dissection is that you will get lot of edema, swelling of the arm. So, that is very cumbersome. You know, patient's quality of life is pretty bad in this. This is for early stages, you know, random assignment, sentinel node biopsy is done. If it is negative, no additional treatment. If it is positive, then either we go in for dissection of the total nodes or we go in for radiation therapy. Now, basically axillary radiotherapy, there is a recent trial called AMAROS trial. What is AMAROS trial? That either we do dissection, ALND means axillary lymph node dissection, ART means axillary radiotherapy. So, if we do radiotherapy or we do surgery, the 5-year survival, overall survival is same. 5-year disease-free survival is also same. And but you see here lymphedema, as I was telling you, lymphedema means your swelling of the arm, which is 28% in the surgery arm and half 14% in the radiotherapy arm. And recurrence is pretty same. It is not statistically significant. Now, if we see stratification for radiotherapy, adjuvant radiotherapy after BCS, BCS means when we are preserving the breast, we are removing only the lymph nodes, only the breast lump, we are not removing the whole breast. And here also you see as you see the study in 6,000 patients with node negative disease, there is 5-year gain of 16%. And on the other side, if you see on the right side, there is 15-year gain of 5%. So, that means that radiotherapy after breast conservation should be given to all. Radiotherapy to the breast I am talking about, not radiotherapy to the armpit or axilla. Now, here you see the stratification of radiotherapy after BCS, 5-year gain in node positive disease. Earlier we were talking of node negative. This is node positive disease. It is to the tune of 30%. And here you see 15-year gain is also 7%. But on the contrary, if you remove the whole breast, then you need not, the 5-year gain is only 4%. And here you see the 15-year loss is 3.6%. So, that means you do not need radiotherapy if they are nodes negative. If they are nodes positive, even 1 to 3 nodes positive, we need radiotherapy after mastectomy also. Nowadays, we have 7 gene signatures for post-mastectomy radiation. Post-mastectomy means if you have removed the whole breast. Now, if you see here also, as you see in these slides, so 5-year gain is 17% here, and you see the difference between mastectomy plus axillary clearance and mastectomy plus chemotherapy. And so, chemotherapy also helps in reducing locoregional recurrence and your distant metastasis. Now, ipsilateral breast tumor recurrence. Again, here you see whether we should give higher radiation dose or less radiation dose. Here also it makes a difference, but here we see the benefit of boost is more in the younger population and not in the elderly population. Now, there are various trials, START-A trial, where we give 50 gray in 25 fractions, which is a conventional fractionation. And here you see we are trying to reduce the time of radiation. Why? Because people have to come for 5 weeks. 5 weeks is too cumbersome for people to come. So that is why we reduce the time, and in START-A trial, they have shown that it is equivalent to your the giving conventional radiation for 5 weeks. Here START-B trial also, here you see lower down, it is 40 gray in 15 fractions in 3 weeks, and this is also equivalent to your 50 gray. And here you see loco-regional recurrence is not different in 50 gray and 40 gray arm. What I mean to say is that even if you give lower dose in a shorter time, that is equivalent to high dose in a long time. So that means you can reduce the duration of radiation, so that patients don't have to come, they are coming from far off places. They don't have to come every day, and they come 5 days a week, and they can finish off in 3 weeks. And here you see loco-regional difference is not, again in the START trials, hypofractionation we call it. Hypofractionation means it is less than the conventional fractionation of giving over 5 weeks. And disease-free survival is also not different in the 50 gray and 40 gray arm. And here you see disease-free survival, again 50 gray versus 40 gray is same. Now here you see 5 weeks and 1 week treatment is also associated with equal disease control. Now what in the UK they are trying to do is to reduce further from 5 weeks to 3 weeks. Now they are trying to reduce it to 1 week. So 1 week is also pretty good treatment, because then patients won't, most of the patients don't want to come for radiation treatment because it is a long treatment, especially in the US. They are trying to avoid it, but then they get recurrence or they get distant spread. Now here you see the UK import high trial, 40 gray in 15 fractions, that means 3 weeks, and this is 36 various different fractions you see, and they give you all results. Fast forward, these are the trials ongoing, just to tell you that even in 1 week you could finish off the treatment. Now this is showing you accelerated partial breast radiation. What do we mean by accelerated partial breast radiation? Because here we want to tell you that the partial breast radiation is done by brachytherapy. This is called brachytherapy. We put in the needles in the breast, we put in the needles and then we radiate. This is called brachytherapy, and here you see all the catheters are in place, and this brachytherapy can deliver radiation to the breast local area. So we are not giving to the whole breast, we are giving only to the local area, and that also is equivalent to whole breast radiation. So this is another modality by which we can treat breast cancers. Now another thing is, these are various instruments, Mammocyte, Contura, Savi, all this which you are seeing, Target. These are all for partial breast radiation. We introduce inside the breast cavity where we have removed the lump, and then we give them radiation, that is local radiation. Now adjuvant chemotherapy, here as I told you, these are various genetic tests which we are doing now. What are genetic tests? That we do 21 gene signature on Oncotype DX. We do 50 gene signature in PAM50, and MammaPrint we do 70 gene assay. All these genes assays, what are they for? They are to tell us the risk of recurrence. So what is the risk of recurrence? If risk is low, then we give only hormone therapy. If risk is high, we give chemotherapy. If risk is intermediate, then there are various studies going on whether to give chemo or not. So that we'll know only after the studies are there. Assessment of risk of recurrence and prediction model. This is PAM50 new gene signature has come. This tells us the risk of recurrence. So what is the risk of recurrence? We can know by these signatures. Now again, a drug, as I told you, there are estrogen receptors, there are progesterone receptors, hormone receptors, and there is a gene called HER2 gene. So that for that gene, if it is positive, we give a monoclonal antibody which is called trastuzumab, and this reduces the risk of recurrence. And you see in this study also, it is reducing the risk of recurrence. Overall survival is better and disease-free survival is also better. And these are called forest plots. It favors the Herceptin arm. Herceptin is H, which earlier used to be called Herceptin. Now it is called trastuzumab, and on the left side it favors your ACPH, the trastuzumab arm. So all the areas, age, hormone receptor, tumor size, nodal status, all favor your trastuzumab arm. That means that trastuzumab can be helpful in all the cases where HER2 gene is overexpressed. Now here you see how the graph has gone. First we used the CMF chemotherapy, then we used anthracycline based chemotherapy, then taxane based. These are various drugs which we have come of age, and then trastuzumab short therapy. Then HER2 gene, as I showed you, the trastuzumab blocks it from top, and we have dual blockade also from bottom also, which we call it, the receptor has three parts, like upper part and lower part. In between there is a transmembrane part. So active are only two parts, the upper part and the lower part. Upper part, the trastuzumab acts. The lower part, tyrosine kinase inhibitors like lapatinib, they act at the lower part. So there is a dual blockade which is coming up, and then dual blockade with longer chemotherapy which is coming up now in the future. Now HER2 therapy in the neoadjuvant. Neoadjuvant means that before doing surgery you give HER2 therapy, right? So if you are giving HER2 therapy, that means trastuzumab in earlier setting, then you reduce the tumor size, and here you see that study arm with trastuzumab, and these are various options, and the pathological complete response is much better when you are using with trastuzumab. Now adjuvant therapy, chemotherapy for breast cancer. What do we mean by adjuvant chemotherapy? Adjuvant chemotherapy, we mean that after doing surgery, if a patient has done surgery, then after surgery whether to give chemo or not, that will depend on the biopsy report. Biopsy report means ER, PR and HER status, estrogen receptors, hormone receptors like progesterone receptor, and HER2 status. Now if you see the adjuvant chemotherapy, the aim is to improve the long-term disease control, reduce the systemic metastasis, control of micrometastasis used for locally advanced disease. Now why do we give adjuvant chemotherapy? Because we may not give chemotherapy to anybody, because we think that we have removed the lump or we have removed the whole breast, but there is microscopic disease in the blood for which we are giving this adjuvant chemotherapy. And these are the agents, the alkylating agents, antimetabolites, antibiotics, all these are agents. And this is a cell cycle which I am showing you, which has DNA synthesis phase, S phase, G1 and G2 are gap phases, and M phase is called mitotic phase. Now evolution of treatment, if you see from 1900 onwards, 1896 or round about 1900, we had radical mastectomy that was found by Halsted, and as we are coming, we added radiotherapy, then chemotherapy, then hormone therapy, then we came to breast conserving surgery, from the whole breast removal to partial breast removal, and then we came to dose dense chemotherapy, And now we have come to targeted therapy, which you see on the right side of your slide. Now, if we see adjuvant chemotherapy of primary breast cancer, what do we know? Chemotherapy improves disease-free and overall survival. Polychemotherapy means more than one drug is better than one drug, monochemotherapy. Multiple cycles are better than single exposure. No major advantage to durations if you give for more than 3 months or more than 6 months, because 6 cycles are sufficient, and sometimes we are giving 8 cycles. So anthracycline combinations are better than CMF, which we were using in 1970s. And late 1970s came your anthracyclines, which we call it CAF. A means adriamycin or anthracyclines. Now, adjuvant chemotherapy, what else do we know? Adriamycin doses, these are just to show you that proper doses should be used for adriamycin, cyclophosphamide and other chemotherapeutic agents. Now, if we see evolution of chemotherapy in node-positive disease, from CMF we came to CEF, FAC and taxanes. These are all the trials which show you the latest chemotherapy drugs which we have come. This is evolution of chemotherapy for node-positive disease. Now, what about hormones? Hormones we have, you must have heard of tamoxifen, which is widely used. Tamoxifen is used for premenopausal, and for postmenopausal we have aromatase inhibitors, which are non-steroidal and steroidal. Non-steroidal are anastrozole and letrozole. Steroidal are exemestane, and then we have fulvestrant. Now, we have to strike a balance. If here you see how is the balance struck. If a patient is on tamoxifen, then we are afraid of endometrial hyperplasia. That means the thickening of the lining of uterus, which is called endometrial hyperplasia. It may lead to uterus cancer also. And there are thromboembolic phenomena, means there may be a thrombosis in the veins. But in aromatase inhibitors, we have the fractures, we have the bone density coming down. So we have to balance between the two. And there is a switch therapy also. That means you give 2 years of tamoxifen followed by 3 years of aromatase inhibitors. So here you see long-term effects of adjuvant tamoxifen. This trial was done by us also, and we find that 10 years is better than 5 years. This is just to show you that effect of anastrozole and tamoxifen. Both drugs can be effective. As I told you, anastrozole in postmenopausal and tamoxifen in premenopausal. Now, 5 years of letrozole combined with your tamoxifen, you know what they have shown, that hormone therapy for premenopausal should be tamoxifen, for postmenopausal should be aromatase inhibitors. Now, letrozole is aromatase inhibitor and tamoxifen is, here you see the tamoxifen is better than your letrozole. Why? Because most of the patients were premenopausal. So they have to be given, the PFS we call it, progression-free survival, was better without impact in overall survival. Now again, if we see the adjuvant tamoxifen and exemestane. Exemestane is another drug which is aromatase inhibitor. This is also a team trial, and here also a randomized phase 3 trial where it shows they are practically equal. And here disease-free survival was not different in both the arms. Now you see overall survival also was not different in both the arms. So in nutshell, I want to tell you that premenopausal or perimenopausal 5 years of tamoxifen, but now it is 10 years. In perimenopausal, not confirmed. Then when you are not sure patient is postmenopausal, don't give aromatase inhibitors. You have to give 10 years of tamoxifen now. Now in postmenopausal, what you should do? 10 years of tamoxifen or 5 years of AI, aromatase inhibitors, or 5 years of tamoxifen plus 5 years of AI, or 2 to 3 years of tamoxifen plus 5 years of AI. Now how do we say this? These are done by evidence. We have evidence by various trials. And here you see the double-blind trial, we call it effect trial, which says fulvestrant is another drug which is very good, and this is purely estrogen inhibitor, and this also leads to better survival benefit. And this is one of the confirmed trial where it showed that 500 milligram is better than 250 milligram. And this is also the final results of the fulvestrant trial, which shows you 500 milligram is better. Now, oxymestane versus anastrozole, again both are aromatase inhibitors, so they are both same. So that is not, there's no difference in overall survival, and there is no difference in disease-free survival. Now here these are important studies, tandem study which we did in our institute also, and this is a global study. All these are global studies. Here if a patient is HER2 positive and hormone also positive, now you have to give drug against HER2, which is trastuzumab or lapatinib, and then use with anastrozole or letrozole, that means with hormones. And you find hormone therapy alone 2.4 months survival, and you find hormone with HER2 is 4.8, it's double. So virtually you get better survival if you attack all the receptors in breast cancer. Now hormone resistance can be intrinsic. Resistance may develop de novo, that means initial exposure, you don't know whether a patient is developing resistance or not, or acquired over time. Now, so you need a targeted agent. Targeted agent means that you are modulating the tumor biology. So which pathways are you signaling? You are signaling the EGFR pathway. This is a new therapy coming up, RAS, RAF, MAP kinase pathway. All these are the various sonic hedgehog pathway, WNT pathway. All these are new molecular pathways. So we can target each pathway if it is overexpressed in breast cancer. Now here you see the PI3K mTOR pathway. PI3 kinase is another gene which is amplified or mutated in 20% of the breast cancers. And if we add drug against PI3 kinase, we can get better results. Now this is a cartoon where you see how the signal transduction takes place. At the top, you see a ligand attached to a receptor, and the receptor then throws downstream signals, either the RAS, RAF, MAP kinase pathway. You see on your left of the slide, you see the PI3 kinase AKT mTOR pathway on the right side of your slide. What I want to show you, that this is a cartoon to show you that receptor is activated and how it is activated by various pathways, and then the signal goes to the genes, and these genes get amplified, and this is how the tumor grows. And we have to block these pathways depending on which pathway is mutated. And here you see the Bolero 2 study. Bolero 2 study was a study where they found that oxymestane gets, once we give oxymestane to a patient, aromatase inhibitor, patients develop resistance. Now how to avoid resistance? Then we blocked the mTOR pathway, which I showed you earlier, with everolimus 10 milligram daily. And once we block it, and here you see everolimus plus oxymestane, the local assessment, the probability of event was much less with oxymestane plus your everolimus. Here also you see central assessment also, better survival with everolimus. Now everolimus can be used with trastuzumab also, because that can avoid resistance in Bolero 3 trial. Here you see progression-free survival and overall survival. This is forest plot, as I showed you earlier also, and this shows better response with everolimus. So what I want to tell you, that breast cancers are on the rise, number one. Number two, we must avoid overweight, obesity. Number three, physical activity we should continue. We should not come home and sit at just see the TV. And I am not against television. I am just saying that sedentary habits should be discouraged. And number two, if you have a family history of breast cancer, then you must get your checkups done. Either you do breast self-examination after the age of 20, after the age of 30, clinical breast examination, after the age of 40, mammograms if required.
With this note, thank you, sir. Thank you so very much for explaining us in detail that what could be done and how could breast cancers detected. Now, my question arises, as you yourself said that obesity is one of the reasons for the cancers. Could we say that this obesity is also the cause of the cancers among males also?
Yeah, obesity, because in male breast cancer, we have not found obesity, but we have found gynecomastia also. You know, gynecomastia means the breast size is enlarged. So, in those cases, obesity obviously has, because obesity produces those hormones which increase the female hormones. So, that is the link between obesity and breast cancer.
Thus, we can say that whether male or female, but he or she must
take care of the health, because obesity you should avoid at any cost.
Exactly, and we would like to tell you all that your eating habits plays a pivotal role for deciding your obesity.
I was coming to the eating habits, because the junk food, as I always call it, I don't say burgers or anything, but your junk food should be avoided as far as possible. Sometimes if you are taking, then it's not a harmful thing, but as a routine, try to avoid the junk food and try to take a food which is rich in proteins, less in fats and less in carbohydrates.
Dr. Julka want to make all our viewers all healthy, away from the diseases called cancer, as well as to lead a healthy life. It is necessary to have a good diet and good food. Though we have discussed earlier in our previous sessions also with other doctors also that alcohols today are the major causes of the cancers. Are alcohols could be one of the reasons for the breast cancers?
Yes, breast cancer, as I showed you the causes of cancer. Alcohol with smoking, we call it a disastrous thing, because smoking is major disaster, alcohol is an added disaster. So, you should try to avoid alcohol, try to avoid smoking, absolutely. Smoking is more dangerous. No, not that I am saying alcohol is all right, but people say sometimes alcohol we take, just a drink. But still they should try to avoid alcohol, and they should try to avoid smoking, because both, if in combination, it's a disastrous thing.
Both independently are also harmful for you, as well as combo
together
is taken, it is more harmful for you.
Yeah, combo
exactly, sir. Now the question is, as you explained, that the person could be given either radiotherapy or with the help of vasectomy or hormonal therapy, the breast cancers can be cured. Can we say that depending on the stage of the cancer, one of these is given?
No, it's generally a combined modality approach. Combined modality, I mean, if it is stage 1, early stage, if a person comes with a 2 centimeter or 1 centimeter lump, we remove the lump and then do the sentinel lymph node biopsy. As I showed you, first lymph node biopsy. Earlier, what we used to do, we used to remove the whole breast and then remove all the axillary lymph nodes. That gives lot of morbidity to the patient. Swelling of the arm. You must have seen some patients with swollen arms. So, this is very bad. The quality of life is equally important as quantity of life. So, what we want to tell that early stage, why early stage is important, early detection, I always stress, early detection is the hallmark to cure. Why it is the hallmark to cure? It can, first of all, early detection, 1 centimeter lump, 2 centimeter, in West, they detect the lump at 4 millimeter. Here we detected 4 centimeter. So, this is the difference. So, if there is a 1 centimeter lump, remove the lump, no need of removing the breast. You have the organ in place, organ preservation, this is called breast preservation. Remove the sentinel node. If sentinel node is negative, give radiation only, no chemo, no other therapy. If hormone positive, then give hormone tablets.
Sometimes people has also misconception that the radiation therapy or the chemotherapies could be harmful, or they would destroy the other parts of the body. But as you have yourself described in the lecture, that only that part.
Only that part. Like radiotherapy, we give it, suppose it is intact breast, we give it only to the breast. or maybe to the supracleft, depending on the stage of the disease, depending on your factors, like if it is ER/PR positive, like hormone receptor positive, which is a good factor. HER positive is a bad factor, or triple negative is a bad factor. All three are negative, which is a bad prognosis group. So we always say that, and again stage is very important. If lymph nodes are positive, then obviously we have to treat your supraclavicular, your lymph node area also. So what we have shown that early detection can avoid chemotherapy for you, can avoid the expenses, can avoid your unnecessary treatment, and you are free with minimal surgery and minimal radiotherapy. That's all.
Now there is
And
another
if
question.
they are ER/PR positive, then hormone therapy tablets only.
Only.
No.
Now there is another question for you, doctor. Whether it is a breast cancer, because we are talking about the breast cancer alone today. If a person is affected by the breast cancer, but with the help of the doctors like you, the person get cured, could the person have the chances of being affected in the another part of the body?
Yes, yes, definitely. This is why I always say that treatment is very important, but follow-up is more important than the treatment. Why? Because we call the patient at 1 monthly interval, then 3 monthly interval, then 6 monthly interval. Why we are calling the patient? We are seeing the patient at regular interval. So if there is a local recurrence, there may be a local recurrence in the breast area or in the chest wall area where the whole breast is removed, or distant recurrence. Distant recurrence means either in the liver or in the bones. Most common is in the bones of the back, or maybe in brain, maybe in lungs, maybe in liver. So wherever is the recurrence, we can find out. So that is why we call them for follow-up. And follow-up is, again I say, more important than your treatment itself.
When we are talking about the risk of recurrences, are there any tests available with the help of which the person is able to know in well advance that in future he would like to get such kind of a cancer?
Yes, actually, as I showed you, no, if a person has breast cancer, early stage, hormone receptor positive, for them we have shown all the genetic tests. With genetic test, we can know the risk of recurrence. If the risk is high, that means we have to give chemotherapy also besides hormones. So first we give chemo, followed by hormones for 5 years or 10 years, as I have shown. Now, whether a patient will develop cancer or not, that the risk factors are: number one, family history positive. If your mother has cancer, or if your Masi has cancer, mother's sister, or anybody from mother's side has cancer, or anybody from father's side also. And number two, if you have BRCA gene mutation, these are genes which are tumor suppressor genes. They suppress the tumor. And once the genes are mutated, that means there is something wrong with the gene. They are not able to suppress the tumor comes up. So if there is a mutation in the gene, then again you are more prone to get breast cancer. Or if you have certain, like early menarche or late menopause, so then you are more exposed to hormones. Or if you are taking regular pills of hormones, estrogen especially, more estrogens, then you are more prone for developing breast cancer. So you have to avoid all that.
We have to avoid all what Dr. Julka has recommended. Dr. Julka, when we are aware and when we know that there is a genetical problem, and when we have a history that our aunts, mothers, or our distant relatives have been suffered from the breast cancers, so how far and how frequently a particular woman needs to go for the regular checkups in order to detect in advance?
Yes. Now, because outside in US, they don't recommend any breast self-examination. They don't recommend any other thing except mammograms. Now, in our country, because screening is little difficult because of 1.2 billion population, now it must be 1.3 billion population. So, but I always say that breast self-examination, if taught properly, like with the right hand, you see the left breast, with the left hand you see the right breast, and you see all the quadrants, and you see if there is any lump in the breast, if you see if there is any discharge from the nipple, or bloody discharge from the nipple, or if there is any lump in the armpit, then also you must consult a doctor. This is what I say. And immediately consult a doctor. Don't think that this will disappear, this is a small cyst, or this is a benign tumor, which some people say fibroadenomas. This has become a common word now with the young girls. They say it is fibroadenoma, we don't want to go to doctor, because fibroadenoma never changes to cancer. So, but we always say you must show it to a doctor. Whosoever you are going, you may go to a gynecologist, you may go to your surgeon, you may go to your physician. But you must go and show yourself, so that you know whether it is really a fibroadenoma or it is something else. There are certain benign breast diseases which can change to cancer. So that also one has to, atypical hyperplasia and all these diseases which can change to cancer. So what I want to say, breast self-examination, clinical examination by a physician, and then mammogram if any doctor tells you.
These are the tests recommended by Dr. Julka. I hope that all the listeners who might be watching us right now, especially the females, would take this concern into account. Now, as I said, all the females who might be watching us, sir, is there any age group, or we have found in recent studies that this particular age group of girls or the women used to get prone to breast cancers?
Yeah, as the age advances, we always say the risk also advances. But I must tell you that young girls are also getting breast cancer now. As young as 20 years, we have seen a girl who was 20 years and had triple negative breast cancer. So what I want to tell you, that at the age of 20, we recommend breast self-examination. At the age of 30, after the 30 years, we recommend that you go in for clinical breast examination. And after 40, if family history is positive, go in for mammogram. Young age mammograms we don't recommend, because dense breast mammograms are not useful. So ultrasound of the breast is also good modality. But now we have MRI also. So MRI of the breast for dense breast is better than your mammograms. So that also we have another modality for imaging.
You have raised a very good concern over here, Dr. Julka, that in some way or the another, all the girls, whether of any age, or all the women of any age, they should be made aware of the breast cancers. And I think that certain camps should be placed in different schools and colleges.
Yes, we have been doing various camps also, and there are certain NGOs, they are doing certain camps in different areas, and they are examining the females also, and they are telling them how to examine. And this is also being done, because I always say prevention is better than cure. So if you can prevent it, it is much better. You know, 11 lakh new cancer cases are occurring in our country, and out of which 40% are tobacco related. So tobacco related 40% we can prevent by preventing not taking tobacco. This is called primary prevention. Then we have secondary prevention. Secondary prevention is for breast cancer. As I told you, if you can detect early, early detection is the hallmark to cure. Or cervical cancer, cervix, uterus, lower part of the uterus, cervix cancer is also common, but it has become less common than your breast cancer. So for cervix, simple pap smear or HPV DNA, that is due to human papilloma virus. But today, since we are talking about breast cancer, so I must tell you that breast cancer early detection again is hallmark to cure.
Exactly. Doctor himself saying that prevention is better than cure. If you would take care of yourselves, of course, doctor is going to feel good, because doctor himself doesn't want that his patients or his people to be affected from this particular kind of disease. As we have very less time left, doctor, we would like to ask from you that because with the passage of time, the trends have been changed. If you talk about the rural India or urban India, do we can say that the breast cancers cases or the history is similar in both the Indias?
No. It is fourfold high increase in urban areas. In all metropolitan cities, it is much higher than in urban population, than in rural population. Now, we are trying to find out the genetic factors. We have still not found out which are the genetic, but we can attribute it to living lifestyle, because this breast cancer is a lifestyle related disease. Because in Western population, why it is high? Because of the junk food, because of the sedentary lifestyle, and because of taking pills. So here in rural population, they don't do all this, and they do physical exercise. So that is why the breast cancer is low, and they don't take high junk food, that is high fatty food, and they are not obese. So that is why they get less, probably. But there may be a genetic reason to it, which we are yet to find out.
And sometimes it is also seen that in, especially if we talk about the women of urban India, there are certain biological reasons with which the women think of a healthy family for herself as well for her family.
Yes.
Should women take care of the biological processes or the biological reasons through which she goes through?
Yes, she has to take care of all the reasons, because if family history is positive, she knows that she is more prone for breast cancer, so she should go in for regular checkups. If mammogram required, mammogram. If ultrasound required, she should go for ultrasound, depending on what the doctor says. Even if MRI is required, she should go in for MRI. So that what I want to tell, that she should consult a doctor, because a doctor will tell her when to come, what test to do, so that she can detect at very early stage. And Angelina Jolie effect, I must tell you, because Angelina Jolie got both the breast removed. She had BRCA1 positive, BRCA1 gene mutated, so she got both her breast removed. But that is not sufficient. She has to get both the ovaries also removed. But is that the life to lead? Exactly. This is what I am saying. So you must get a regular checkup done. Don't be afraid of the BRCA1 mutation, even if it is there, because nowadays people are getting the test done on their own. They are not asking doctors. PET scan, they do it and then come to us. BRCA1 mutations they are doing and coming to us. So what I want to tell them, not to get any test done without doctor's advice. Number two, they should, even if BRCA1 positive, go for a regular checkup and don't go in for prophylactic mastectomy, prophylactic oophorectomy. Removing all the organs is not the answer.
Exactly. I hope that all the viewers who have watched us would follow the do's and don'ts given by Professor P.K. Julka and would incorporate them in their lives. And we pray for your healthy life. Thank you, Dr. Julka. Thank you so very much for giving your precious time to the Reset lecture. Thank you, sir.